we're all here now. Both those that are here live and those of you on Zoom. So thank you so much. My name's Tiffany Grunwald. I am the Executive Medical Director of the Women's Health and Wellness Institute, and this is the second of our series of patient education seminars. We are super excited today to have both Dr. Lisa Valle, who's the owner and director of the Oasis Women's Sexual Function Center, and then Laura Summerton, who is a pelvic floor physical therapist. She has a doctorate in physical therapy and has an amazing passion for teaching women about sexual health. So sexual health and wellness has a lot to do with women's health and wellness, and so we're all going to learn today. Lauren Summerton's going to start, and then Dr. Valle. They're both going to give you a little presentation, about 10 minutes. If you're on the Zoom, please put questions into the chat, and we'll do that afterwards, because our goal is to have this very interactive and have, all of your questions answered. These are two amazing women who have dedicated their professional lives to women's sexual health, and I think we're all going to learn a lot. All right, and then share it with your partner. Okay, so I'm going to invite Lauren up now. Thanks. Thank you. From our studio audience.
Thank you, Dr. Grunwald. Hello, everyone. I'm Lauren Summerton. I am a pelvic floor physical therapist, and I work here at the Women's Health Institute. And I'm really excited to teach you all a little bit about sexual health and then answer your questions. Because the more we talk about sexual health, the more we can get our questions answered and normalize a lot of what people are curious about. So what I'll do first is I'll define what pelvic floor physical therapy is and the pelvic floor muscles, their role in sexual health, and then how we treat sexual health through transitions, focusing on postpartum and then menopause. Okay, so pelvic floor physical therapy is physical therapy with a specialization in the muscles at the bottom of the pelvis that support the pelvic organs. So the same way if you went to physical therapy for back pain or knee pain, they look at your posture and your strength and your flexibility. We do the same thing, we just focus in the pelvis. And we look at the rest of your body too, but we focus on conditions that are related to the pelvis. So who do we treat? So pelvic floor physical therapy generally treats all genders of all ages, so from pediatrics up through adulthood. And at the Women's Health Clinic, I see women and women's health issues. So basically it's things that involve bowel, bladder, or sexual function. So just to name some common diagnoses that we treat would be like urinary incontinence, overactive bladder or urinary urgency frequency, pelvic pain anywhere in the pelvis, pain with intercourse, pelvic organ prolapse, constipation, fecal incontinence. And pelvic floor physical therapists are also trained to work with people who are pregnant or postpartum and the unique changes that their bodies go through too. Okay, so the pelvic floor. So the pelvic floor is the group of muscles, fascia, and connective tissue that go between the pubic bone and the tailbone. So I love the pelvic floor because it does many different functions. So we'll get to sexual function, but it also provides support for the pelvic organs. So because of where these muscles are, it supports the bladder. In women, the bladder, the uterus, and the rectum. These muscles control the sphincters too, so they close to hold poop and pee in, and they open to let poop and pee out. They function as part of your core muscles, so they provide support for your trunk. They have a sump pump function, so because of where they are, they help fluid flow from your legs to your trunk. And then they play a role in sexual function, so orgasm and penetration. All the fun stuff. So this next slide, so this is a picture of the pelvic floor muscles. This is not what they look like in real life. They're not color coded, but I wish that they were, because they're very fun to look at. So this just goes to show you how many muscles are in the pelvic floor. And So for an orgasm is a rhythmic contraction and relaxation of these muscles. So it's important for sexual health to have good awareness of where these muscles are, how to squeeze them or how to strengthen them, and then also how to release them. That's one of my soapboxes, which I'll get to later. Learning how to relax these muscles is really important. And then for penetration, so in this picture, the pink muscle that goes around the vagina, there's muscles that surround the opening of the vagina that have to open or be flexible to allow for penetration. Most times when people have referrals for pelvic floor PT, it's because they have pain with penetration or discomfort with sex. And it's usually because kind of two things. One is the tissue is dry, which I'll talk about, and then also that these muscles are too tight. So if you think about the muscles in your neck, like, has anyone ever had a tension headache? So if you have a tension headache, it's because the muscles in your neck get tight and so your head starts to hurt. And the muscles in the pelvic floor are the same type of muscle. So if these muscles get tight, they can also create pain signals if you go to have penetration. So sexual health through transition. So people get referrals for treatment of pelvic pain anytime throughout the lifespan. These are kind of the most common reasons why people come to the clinic. If they kind of go through like a pain-free sexual life and then they start to develop discomfort, they tend to tell their doctors and then come to pelvic PT. So for postpartum, so the birth process, so vaginal births can impact the muscles. If there's any birth trauma or injury, so perineal tearing or vacuum-assisted delivery. I think Dr. Valle will likely touch on this, but estrogen is responsible for vaginal lubrication. And so when you're breastfeeding postpartum, there's a decrease in the estrogen, and that can cause the tissue to be a little bit more dry, which can make penetration a little bit more uncomfortable. And the vaginal muscles after birth can be either more tight or more relaxed than normal. And so the tightness or that, like the tension headache, the tight muscles, can contribute to painful intercourse. And then if the muscles are more relaxed, that can contribute to a change in sensation. And then for menopause, so in menopause, because of estrogen levels, there can be a thinning or a less flexibility of the vaginal tissues and muscles, which I hear this a lot from patients, is that they go to have penetration and they think, I've had kids, so why is it painful when I go to have intercourse now that I'm in menopause? And it's because of that tissue thinning and tightening. Okay, so the same way if your muscles in your neck were too tight, you would want to stretch your muscles and massage them and get the tension to decrease. So the same thing, if people come in for pelvic pain, we just do the same thing, but for the muscles on the inside. So there's manual therapy and stretching that we do in the clinic and that patients do as part of a home program. Hip stretching, that opens up the pelvis. So like for yogis, like happy baby pose and child's pose. How we breathe and our posture affects our pelvic floor muscles. So we address and try to balance that. And then at the bottom, they're called like vaginal dilators. And then the top right is what's called a pelvic wand. And those are same way you have a neck massager for your neck. These help massage the muscles, but on the inside. Treatment. Okay, one of my soapboxes. So is that if you went to a physical therapist and you said, oh, my knee hurts, and they just handed you an exercise program without doing an assessment, you might question, is this the right program for me? So it's the same thing for the pelvic floor. And I'll get to Kegels in a minute, but saying that everyone should do Kegels is kind of saying everyone with knee pain needs the same program. And it's not that way. So it's really important that you have a pelvic floor muscle assessment to see if your muscles are tight or if they're weak, so you get the right program to help your muscles be balanced. So if the muscles, first we do an exam to see what your muscles need, and then if the muscles are tight, we teach you how to relax, how to decrease the nerve sensitivity. The muscles in research, the muscles of your jaw, your neck, and your pelvic floor are connected because they're kind of connected to our mood states, right? So by learning how to relax your body, you can learn how to relax your pelvic floor too. And then to improve hip muscle flexibility too, because it's connected to the pelvic girdle. Okay, common questions or myths that I hear a lot, either from out in the world, on social media, from my patients, is like, I heard everyone should do Kegels. Is that true? This is like, so we're never really like proud of anyone if they have a really tight back or really tight hamstrings, but there's something about the pelvic floor that people are like, tighten it, you know, but we don't treat other muscles in the body that way. So our muscles need to squeeze, but they also have to be relaxed. You wouldn't like work your bicep and then never stretch it, right? You have to have both to have good range of motion and muscle health. It's one thing. I should use lubricant. Yes, 100% of people should use lubricant 100% of the time. It improves pleasure, it decreases friction, it decreases discomfort. The myth that like everyone is just as lubricated for every sexual encounter and as long as they want to be sexually active for is a myth. So lubricant is great. And then can my pain with sex get better? Yes, there are research studies, there's evidence, there's help. I treat it clinically all the time and people get better. Same with my colleagues. So I would recommend if you have pain with or any discomfort with sex, like tell your doctor. OBGYNs have great resources. Mental health therapy can also be helpful. So there's hope, there's programs, there's plans, and just like talk to your doctor about it. And that wraps up my portion. And that's not me surfing, but I wish that it was. All right, thank you guys.
Oops, you can stay up here. Thank you so much, Lauren. So there's a bunch of questions. I think we're going to hold them until Dr. Valle is done. And we're just trying to load her her slides. So maybe one of the questions that came in was who can refer a patient to you? Mm-hmm. And does insurance cover it? And if you can answer that, I'm going to help loading these slides.
Yeah, I'm assuming that everyone on the call is in California, except my mom. Hi, Mom. But I'm assuming that everyone else is in California. So in the state of California, we have what's called direct access. So if you are part of a hospital system, you need a referral, and you can get one from your OBGYN, primary care, urology, any MD that you feel comfortable talking to about this can refer you for pelvic floor PT.
Amazing. And then there was one other question. I loved your analogy about the tension headache.
Yeah.
Right? But we do massage for a tension headache.
Uh-huh.
So is it kind of the same thing? Is pelvic floor physical therapy doing massage for those muscles that are tight?
Good question. So
It wasn't mine, but I'm going to take credit for it because I read it.
If you went to PT for tension headache, there's research that your posture is related to tension headaches. So the same way, if you have like a muscle tightness and you get a massage, it's better for a certain amount of time. But then if you have the same like postural patterns, it'll come back. So yes, PT part of it is like massage that you can do either clinically or at home. Those tools are great, but it's also how you breathe. Are you stretching? How's your stress levels? So the same way we treat tension headaches clinically, it's like a little bit more of a general picture. Kind of a yes and, which PTs are famous for saying. It depends and yes and.
It is good, and I'm sure Dr. Valle will talk about all of the same stuff. But so one of the other questions that came in was, do you discourage vaginal deliveries? Because you keep talking about after vaginal deliveries, and they said somebody said they should only have a C-section.
Ah, good question. And I want to say I'm sorry if I made it, I'm nervous, and I'm sorry if I made it out to seem like there's anything wrong with vaginal deliveries. There's not, and I can't really speak to if it's recommended or not for someone to have that. That's above my pay grade. That'd be for OBGYN.
We'll talk about it.
But I would say that postpartum, yeah, and postpartum, like if you are having symptoms, there's help, and I've treated people for painful sex after C-section too. So have babies, they're beautiful and great and cute, and I'm happy for everyone who has them.
Really appreciate you, Lauren. So Lauren's going to stick around for the question and answer part, but Dr. Lisa Valle, come on up, Lisa, who, as I mentioned earlier, is the owner and director of the Oasis Women's Sexual Function Center.
I'm happy to be here, and I was asked to kind of discuss a little bit about what I do and how some transitions through a woman's life affects their sexual wellness. And I'm going to talk about what a female sexual medicine provider does, and I'll kind of go just briefly. Try not to make it too many medical terminology. I tried to make it as simple as possible. I have no financial disclosures. So we're kind of talk about just kind of like from a medical perspective, changes after childbirth, perimenopause, menopause, and how each of these affect female sexual function. Okay. So first, like, what is female sexual medicine? So I am I was a trained board certified OBGYN, and through the course of my career, I actually got trained on female sexual medicine disorders. So my office solely focuses on female sexual pain disorders and other sexual disorders, and I see a lot of hormonal changes associated with childbirth, perimenopause, menopause. Those are one example. And I'm just going to I'm sure she did a little quick review of anatomy, but this is the clitoris. And when we're talking about any kind of female issue in terms of things that cause pain and things that affect a woman's lifespan as far as sexual function goes, we talk a lot about the vulva. So, and I always do a lot of education in the office with a mirror as far as educating on a lot of pain and discomfort from, for example, lactation and the changes of menopause. Those start to thin these tissues at the opening of the vagina. So I see a lot of that. But remember that the vagina is the opening, and everything else that you see outside is like the labia majora, the mons, the clitoral area, the perineum. Everything else is called the vulva. So I always make a distinct distinction because a lot of patients aren't aware. And so when they're describing, I have itching or I have pain, I want them to be able to communicate exactly what that is. So we talk about the branches of the pudendal nerve, like just think of like a tree, and there's all sorts of branches to the opening that can contribute to pain. And we have the pelvic floor muscles, which I think Lauren had discussed. And then when we talk about hormones, it's not just estrogen. So we actually have more testosterone as a female than we have estrogen, and we make our estrogen from our testosterone. And it's kind of like the forgotten hormone, because for the longest time they would assume it's just for sex drive, but we actually need it in the vaginal tissues at the vestibule for our sexual organs like the clitoris and things like that. We need it for motivation in the brain. So, but it's kind of a forgotten type of thing. And when we're talking about anything of female sexual wellness, we want to talk about a biopsychosocial model of female sexual response. So here, this is kind of where I play into it as far as a biological things, like things that can cause pain. So it can be hormones, it can be infections, it can be pelvic floor things. And so we look at kind of the endocrine function, the pelvic floor, tissue, because sometimes there's dermatological things that occur through a woman's life. And then from a broader perspective, I actually like to look at all of the things that influence sexual function. So we're talking about like a psychological issues like anxiety, depression, interpersonal issues with their relationships, sociocultural. I always ask them about, when they were little, how do they learn about sex education, cultural or religious influences, and things as such. So when we talk about sexual wellness, I like to call this page like kind of like a symphony of neurotransmitters and hormones. So it's not just testosterone. There are medications that we give patients that affect these things, like SSRIs for depression. There are things of lactation, for example. It elevates our prolactin, and that can affect things. And so there's a whole array of things that affect that. And so when we go back to this biopsychosocial model for care, I usually collaborate with the pelvic floor physical therapist. I actually spend a lot of time talking to sex therapists, psychiatrists, where I try to get them to change medications if they have a sexual side effect. And then we kind of together devise a treatment plan to reduce the pain. And this, when they look at studies, this is usually the best way to approach anybody with, for example, sexual pain. So when we talk about childbirth, I always put little pictures of animals because I like animals and I love this picture. Anyways, it's been a long day. And they actually came up with the name genitourinary syndrome of lactation. So for the longest time, there are a lot of things that occur, like when we give certain medications, and menopause and perimenopause and lactation. So my colleagues actually did a paper that's, and they actually called it genitourinary syndrome of lactation. And it's basically just describes what happens during breastfeeding because of the elevated levels of prolactin, which is a hormone that's produced in breastfeeding. It suppresses your hormones, and basically what happens is that the tissues get very dry, very, very thin, and a lot of females will get like dryness, burning, itching, pain with sex, urinary symptoms. They then develop like pelvic floor issues, and it's like this whole issue, and it's actually very treatable because for the most part, if you go to your OBGYN, most of them will prescribe estradiol cream. Sometimes that fails to alleviate it, and that has more to do with the nuances of like where exactly the pain is, because at the opening of the vagina, there is actually testosterone receptors, so they also have pain from that. And so we give just local hormonal things like estrogen and a little bit of testosterone in those areas if somebody has pain with sex. But for the most part, most people just need estradiol cream to fix this. And then once they stop lactating, your tissues go back to usually normal. And we talk about perimenopause and menopause. So remember that menopause is 12 months of no periods. Perimenopause is that transition time, and I call it a decade before. They used to say 2 years. I don't think it's 2 years. I think it's like a whole decade that occurs before that, because if you think about things that occur in perimenopause. So I always kind of review, okay, so it's time to make sure that you track your periods. Are your cycles getting a little off? Are you ever feeling warm? Do you wake up at night warm? Do you have hot flashes? Do you have night sweats? Do they once in a while come back? Do they go away? Sometimes people will get brain fog during this period. I call it kind of a cotton ball brain, so to speak, word finding issues when you're trying to search for a word and you can't quite get there. Skin dryness, eye dryness, mouth dryness, food doesn't taste the same. There's all sorts of different associated perimenopausal symptoms that just in general, people just don't talk about. But one of the things that starts to occur is that there's a small percentage of females in this decade where they actually start to get thinning tissues. And so one of the more common things is actually I'm going to back up, I'm not quite there yet, but is they start to get, like, for example, recurrent UTIs. And sometimes that's a function of thin tissues. Sometimes they start to get chronic vaginal infections during this time, and it's because their tissues are starting to thin. And then once you hit menopause, that's 12 months of no periods, the tissues start to usually get worse at this point. And so usually we get dryness, pain with sex, itching, burning, soreness, tightness. You start to lose a lot of the elasticity. Again, the recurrent UTIs. Sometimes the vaginal vault gets a little bit short, and we have diminished blood flow. So, and they basically estimate that at least 50% of postmenopausal women usually have significant genitourinary syndrome of menopause symptoms. It's usually chronic, progressive. Symptoms don't improve without treatment. The standard treatment is to say, okay, first try moisturizers, which add moisture, use lubricants, but for the most part, by the time they usually go to the doctor, they've already tried all of those things, and so I'm a big proponent of vaginal estrogen or other things that can actually help that. And that's kind of what I decided to focus on for today. That's it.
So One of the questions that I got was, so this is for Dr. Valle. So who refers to you?
Okay.
And what are the main reasons why doctors refer to you?
So the most common people that refer to me are usually other pelvic floor physical therapists, sex therapists, OBGYNs that know what I do. I don't do regular gynecology like pap smears and things like that. Usually I'm like the kind of case where like the gynecologist has actually gone through all of everything that they've done and they're like, okay, I need another look and someone else with more expertise to see. And so I usually get a lot of referrals that way. So those are the most common.
Okay.
Yeah.
And you already answered that, Lauren, about like who refers to you. I have a couple more questions that came from the Zoom, but do you guys have questions out here?
When does perimenopause start?
So they say 2 to 8 years. I usually say 8 to 10, but yes, usually around 2 to 8 years prior to menopause. So menopause is 12 months of no periods, which is why it's important to always track when your periods are, because before you know it, sometimes some women will go menopausal at 43. And before you know it, you're trying to think, when was my last period? And it's important to note that because any bleeding after menopause is postmenopausal vaginal bleeding, and that always has to get evaluated. So that's why I always tell people make sure that you track.
Do you have a favorite tracking app?
Not really. I mean,
There's a bunch of apps. Right?
anything that actually, anything that actually gets
Helps you track.
to actually track. Yeah. So.
So the other question was, I think you mentioned that our testosterone levels are higher than estrogen. So someone asked, is the testosterone level then more important that you replace it?
Well, that's a whole controversial.
It's a whole controversial thing,
Yes.
which I think is why they brought it up.
In other countries, like for example, Australia, they actually have an FDA-approved systemic testosterone that you put on your skin for example, decreased sex drive in a menopausal female, and they're kind of far beyond us now. They have actually attempted to get an FDA approval for testosterone here, but there was a lot of, I won't go into all the details of that, but there's a lot of politics with that, and they wanted more studies, and doing those studies takes a lot of money.
Do we have the topical testosterone, or like what are the ways patients take
usually
testosterone?
what happens is, for the most part, and I'm a member of ISHWISH, which is the International Society for the Study of Women's Sexual Health. So we actually have guidelines of how we actually prescribe.
It's a good name for sexual health.
Testosterone, yes. And in that, what happens is we usually do it through the skin. And traditionally, we usually get either a male version, so that would be 1/10 that of a male version, and those are very expensive. Insurance doesn't cover it, unfortunately. Or there's another way of doing it by from Australia. I can actually write a prescription, and they can order just one tube. You can't order like a whole bunch of tubes, but that's another way. And the reason why is because we don't necessarily compound that. Compounding is when I give them a recipe at the compounding pharmacy. Because when I'm giving systemic testosterone, I want the level to be very stable. And when it's compounded, that's okay for local tissues. Like I'll give it, like if somebody has pain at the entrance, at a much lower dose, because we're not doing that for a systemic, like sustained release. And in the jar, the concentration is not the same throughout the jar. So frequently I will see there are gynecologists prescribing that, but we don't necessarily prefer that, because what happens is if I check a level, your testosterone will be high one day and the next level will be low, and like I'm trying to emulate what a premenopausal woman would be, and it's really hard when it's compounded.
Interesting. So Lauren, let me just expound this question a little bit for you. Do you see a difference in patients when they're taking testosterone or estrogen, and what do you do with patients? Where do you refer them if you're seeing them and you're like, maybe you should be taking testosterone or estrogen? How do you handle all of that?
I see patients who usually, because patients come to me through referral from OBGYN or urogynecology, they usually have a prescription for estrogen because they're coming to me for a painful sex. So patients who use it they really see a difference. They're much more comfortable, not just with their sexual health, but their urinary symptoms too. So I hear really good things about people who are the right candidates who have been using estrogen cream. Like, it really makes a difference. I have noticed in other jobs where I've thought that people could benefit from it, and so I'll message the referring doctor and be like, hey, I'm thinking this, what do you think, right? Because it's not my call, but I'll suggest that. And then I haven't seen people who supplement who use testosterone. That's just what I've seen clinically. I haven't seen people with that. So.
Okay.
But estrogen is see good
So
things.
there was another question, Dr. Valle, you brought up a sexual therapist, and I think I'd like to hear from both of you how you interact with the sexual therapist.
Yes.
Because there's so much, well, a lot of people don't even know that there's pelvic floor physical therapists,
Yes,
right?
yes,
Or
yes.
that there's a sexual wellness
Yes.
practice.
Yes.
And so can you kind of destigmatize the sexual therapist and what that
Sure.
all entails?
Sure. A sex therapist is someone that officially has some kind of mental health training. So it could technically be an LMFT, licensed marriage and family therapist. It could be an LCSW, which is licensed clinical social worker. It could technically even be a psychologist. They basically have to get extra training to be a sex therapist. And those are people that specialize they get so many hours, and they're usually ASECT certified, which is, don't ask me what the official abbreviation is, but it's ASECT certified. And what they do is they have to do so many hours specifically in sex therapy counseling, and they specialize in, for example, somebody has sexual pain, sexual trauma, relationship issues with their partner, sex drive discrepancy between their partners. So sometimes there's individual sex therapy where the actual person might benefit because maybe there's some shame about pain, or there's shame from their upbringing, or they might have some sexual trauma, or they have medical trauma from their sexual pain issues. Sometimes we do couples sex therapy. So there's usually like a separate sex therapist that sees couples, and then they might see the individual. And usually what happens is they get a release and I get a release, and then we usually have like a teleconference with each other so that I can explain to them what their medical condition is. So I actually take care of a lot of what's called vestibulodynia, which is pain at the entrance that I was showing you at the entrance. And I usually will kind of walk through like all of the pain generators and like what is contributing to their pain. So the sex therapist usually is already familiar with what those are. In fact, this past weekend I actually gave a lecture to a bunch of sex therapists this past weekend. But so they already usually have training in a lot of these different things. They're familiar, and so they may not come from a medical perspective, but from a mental health perspective, they can actually help the patient kind of process it, kind of walk through and understand what they're talking about.
And that's in close collaboration with you.
Yes,
And
yes.
So Lauren, can you talk about how you interact with sex therapists also?
Yeah, I agree. Sex therapy is wonderful. Some sexual challenges that people face are like narratives that they have inherited and then believe about themselves, and that can be a barrier. And also there's a research study that the best cure for pelvic pain is a team of OBGYN, pelvic PT, and sex therapy. So it's also evidence-based. I refer people to sex therapists that I've talked to. We've done video calls, but I am not I don't follow up with them with the sex therapist directly unless the patient was to ask me. And I have talked to patients' therapists before if we're working, if they have a history of sexual trauma. They also set a release, and then I can talk to their therapist, and they disclose as much as is helpful and as little as meaningfully important. They only give me a little bit of information, but things that can be helpful to work with the patient when I'm working with such an intimate part of the body. So it's kind of case dependent, but I refer to them a lot.
Yeah, I also have to mention that sometimes you have to choose, there are certain sex therapists that are trauma informed, specifically, for example, EMDR, or they do other types of things to help with trauma. So medical trauma is a big thing, because if somebody has pain every time the speculum goes in, or they have something from a delivery and it was an emergency C-section, they have a lot of trauma from that. I will choose specifically a sex therapist that is trauma informed, that is good about trauma like that. There are other sex therapists that are good, like for example, growing up and they had a lot of cultural or religious influences that affect them as an adult. And there are certain ones that are good, so I kind of pick and choose like which one I would send to if they haven't seen a sex therapist yet.
Okay. I have 2 more questions. Did anybody else have questions? Okay, so these are statistic questions, and I'm not going to hold you to these statistics, but I'm kind of curious. So, of all of the patients that you see, what percentage go to pelvic floor physical therapy, and what percentage go to a sex therapist?
Probably in my practice. Now my practice is very skewed because I see like all sexual types of things, and like anorgasmia and things like that. But I would probably have to say 90% see pelvic floor physical therapists because of what I see. That's a little bit skewed because I'm a sexual medicine.
Yeah.
Yeah.
And what about sex therapists?
Probably about maybe half.
Okay.
Yeah.
And then your statistic question is, so of all the patients that you see, what percentage are postpartum, what percentage are sexual wellness, and what percentage are postmenopausal incontinence? Like, how does that? What's the range of patients that you see?
With
I'm not going to hold you to the
with
statistics.
referrals for here, I've seen more postmenopausal women. I have worked, but in general, I would say any given time, I would say maybe like 50% are postmenopausal, 25, maybe 40%, 30 to 40% perimenopausal, like 20 to 30% pregnant postpartum, and then like 20 to 30% pelvic pain. I don't think that adds up to 100, but that's what it feels like. Might be 110, but I'm doing the most. My productivity, my managers say my productivity.
And postpartum, how soon do you see patients postpartum?
So 6 weeks is the general rule for anything internal after they have seen their OBGYN and gotten clearance. And so if they have gotten clearance if they have clearance for like intercourse, then they're cleared to have a pelvic floor muscle exam. But if they, sometimes I get referrals before that, but that would be like if they have hip pain or back pain. So for pelvic floor, after 6 weeks, and they're cleared by their doctor. Before that would be something orthopedic that they're like a little desperate to get help.
Yeah. So I don't think you were quite here yet, Dr. Valle, but Lauren did 3 myths that she hears, and she like busted them. Yes. So when you sit down at a dinner party and people learn what you do, what is the most common question they ask you?
You know, it's funny because the most common question I get asked is kind of like more like a comment. They assume that sexual problems like sexual pain and like all of these different things that I see, they assume that it's all mental.
Great point.
Oh,
And think about like the history of how we've taken care of women throughout history. Yeah. And, like hysteria. And there's a long history of that. It used to be that initially, for example, erectile dysfunction was initially thought to be a psychological diagnosis way back when. And it took a long time to change that narrative, right? And so I think it's still stuck around. So sometimes I will answer that question, but it's interesting because when patients come in, some of them will say, well, maybe this is all in my head, but that kind of thing. But like, some of them do have pain or they have like for real. And I have to tell them, I'm like, no, like this is not normal, to have pain. Like you have pain. There's a reason why this hurts. Yeah. But I think it's like so much into the narrative of just...
And explaining that it's physical.
It's physical. And is there a psychological component to pain? Yes. Yeah. This is like that whole biopsychosocial model.
Sure.
For
it's
sure.
Holistic. It's all mind, body, spirit, intertwined.
Yes. But I always tell them, I was like, that's an important piece to address, but I can fix this part, and then we'll make sure that you address all the other parts too. So.
Yeah. So in the sexual wellness world, and this is for both of you, I'm curious, how long do you think it takes for patients to get to you?
Oh. The number said 7 years for pelvic PT, for pelvic pain with intercourse to pelvic PT, 7 years.
Okay.
From when they first...
And what have they been doing in those 7 years?
Keeping it a secret.
Have they been mentioning it, or
Either one. It can be that they mention it and people are like, you just need to relax, just have a glass of wine. So they're either like placated with these tropes that don't work, or they don't tell anybody. They just might have shame about it, or also they think it's normal. Like some people have had pain since they became sexually active, so they just thought, or like their first time's supposed to hurt, and they carry that narrative forward, and then they meet the right person that's like, So
this, you agree with the 7 years?
I agree, yeah. So for PT, for sure.
Yeah.
It varies in my office, but I just saw a patient that she had seen, I think, 19 physicians before she saw me. And like they were kind of, trying to help her, and they were doing the best they can. But the problem is like, especially like as an OB/GYN, like we only have like so many hours in our residency. And so like, I don't fault them for like not knowing this necessarily, because we have to learn how to deliver a baby, how to manage complications, how to manage surgery, complications from that.
Right.
And there's like so
many
many other topics you have to cover in 4 years. And I'm old now, but like I was in the 120 hours per week way back when in residency. And then somewhere in there, I guess they decreased it to 80. And that's still a lot to people are like, well, that's still a lot of hours per week, but 120 hours versus 80, there's only so much they can cover in 4 years.
Yeah.
So, and they're never really going to increase the residency to 5 years, because you're already dealing with people that have delayed their life during their 20s to like go to school, and like they have all these student loans, and like I think the average medical student now owes like $500,000 or something like that. I mean, a lot of them do, because they go to private school and things like that. But and how are they going to pay that back? And also Medicare funds residencies, right? So they would have to give more money to Medicare to. So there's a whole layer of that. So you have to actually go out and purposely seek education classes on how to do this, and a lot of people don't have the time or the passion to like do it, and I don't fault them for that. But I think what it is because and now just more recently people are talking about it on TikTok, on Instagram, whereas before it was just something that like no one talks about. Like I started this office in 2016, and people are like, oh, I don't tell anybody about this, and now people are more apt to actually talk about it.
It's like mental health.
Yes.
I think sexual health is riding the coattails of mental health.
Yes.
Like before, no one talked about being anxious or depressed, and everyone's like, my therapist said this. It's like trickle down therapy.
Exactly.
I'd also like to share one more thing, if that's okay.
Please.
So one thing back to the mental health therapy. Oh, is it okay if I share this quick? Okay, so one thing that I do when people have pain with penetration, it's like if you ever have worn contact lenses, I learned this this is a reference from a course I took, but when you go to put a contact lens in for the first time, your eye doesn't want to let it in. And then over time, when you keep practicing it, you can be at the restaurant bathroom, like digging around in your eye. So the vagina has the same reflex. So if there's like real or anticipated pain, your nervous system wants to protect you. So part of the pain treatment is also like down regulating that reflex. So the same way that you put contact lenses in many times and you don't have a painful response, and then your body softens to the idea of it, that's also part of it. So I tell patients, like, it's not just your body, it's not just your mind, it's like your nervous system, and that part of that is belief and thought and memories and that stuff. So it's holistic. Sure. I wanted to share that.
Yes.
Go ahead.
That's a good point.
I just remember reading something on like vaginal rejuvenation on like women who have dryness, or sometimes they go and they get like radio frequency, or is this something that you also like recommend, or
by the time that people so by the time that people see me, they've already done some of those things, and sometimes it's kind of beyond that, but some regular gynecologists do that, and they actually find success in those. So they have like lasers, they have all sorts of different things, and sometimes they can help, but by the time they come to see me, they've already done all of those things.
Are those things like work? In some people, yes. Do they always work? No. And sometimes it's because that's not the issue. So
we're looking into it, but they're good.
Yeah.
So this has been amazing, you guys. I really appreciate it. I have one last question before we wrap up, and this is because you have both talked about both the delay in diagnosis or getting help. Most women are nervous when they see their primary care doctor, right? And they're talking about like they need their mammogram or their colonoscopy. So what are the words that people can say that are easier to say than like, I have painful sex, right? Like what is your recommendation now, because this will then live on our website so people will see it. Like, how do you approach that? What do you say? Like, what are the best things to say so that you get referred to one of the two of you?
That's a difficult question.
I know, I'm curious what your answer is.
Yeah. You know, so first of all, I think we need to teach people to try to feel comfortable describing their symptoms. So I don't think we should shy away from words.
Okay.
I think that once
I wasn't shaming.
No. No,
I
you're not.
You're totally right.
But I think it's also the words we use,
Yeah.
and I also think it's up to us as providers, physicians, or nurse practitioners, or what have you, to have an open dialogue. And they actually have done a study on like there's a lot of providers that feel comfortable bringing it up too. You know.
Yeah.
So, but I think it's just a matter of like I would like to talk about. You know, I have some discomfort with sexual activity. Are you comfortable talking about that? And most of the time the provider is, if they do it that way. But sometimes they're not.
But
So,
you're going to have to bring it up.
yes, you're going to have to bring it up.
If you don't ask.
Ideally, I would like it to be a point at which at some point, whether it be family practice or whether it be an OB-GYN, and most OB-GYNs will ask that, but not all. Do you have any problems with sex? Like, do you have pain? Are you able to have an orgasm? Like, is there any, like, discomfort afterwards? That kind of thing. That should be like a routine thing, kind of like, do you smoke? Do you want to quit? That kind of thing. But it doesn't. Not everybody is comfortable, and I think it's because of the whole narrative over hundreds of years of we don't talk about this.
That. Excellent.
So,
Do you have anything to add?
I think I would say like I have some concerns about my sexual function. Do you mind talking about them? So I feel like you shouldn't have to consent a medical professional to talk about sex, but just to let them know that that's what you're going to share. But you could just say I have some concerns, and then they should have the training to follow up and be like, what are your concerns? Do you have pain? So I would say I have concerns about my sexual function. Is it okay if we talk about it?
It's funny because you both said, and we're almost done in time, but you both ended your sentence with, is it okay if we talk about it? Why do you have to ask your doctor permission to talk about it? I'm just curious because you both said it.
I think because not all providers are comfortable with the subject. I have people that will call me and they'll say, can I send you this patient? I really don't feel comfortable talking about this with this patient. And just because some of them don't have that level of comfort.
It's interesting that you both said it.
Yes.
Like
We're
that.
big in like the world of consent.
Yes.
Like we consent our patients.
Yes.
Is it okay if I
Yes.
ask about your sexual function?
Right.
So
Yes.
you're consenting.
Yes.
You consent another human to talk about sex. Like I feel like we
Yes.
implied consent here because everyone showed up. But if you guys didn't know, I'd be like, is it okay if we talk about sexual
Yes.
anatomy? So it's just
Yeah.
part
Right.
of consenting people to talk about something that's sensitive.
Something as simple as like a revisit, I say, is it okay if I show you a mirror, like your anatomy? And for the most part, 100% of the time, they usually say, okay.
Yeah.
But I always consent.
And then it's the provider's responsibility to say, no, I'm not. Here's references for
Yes.
people who might be.
Bingo. Yes.
Excellent. All right, Lauren Summerton, Dr. Lisa Valle.